I'm Dr. Nigil Cletus. I am an interventional cardiologist. I'm working in Indira Gandhi Cooperative Hospital, Kochi. I'll be talking about the latest updates in hypertension. As per the WHO, nearly 63% of the total deaths in India they're due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects almost 45% people in the age group of 40 to 69. Raised BP is among the most important risk factors for cardiovascular diseases. Moreover, it remains poorly controlled due to the low awareness about hypertension, the lack of appropriate care through primary health care, and poor follow up. In India, the prevalence has also gone up over the 30 years to 38% in men and 32% in women, from around 29 and 28% respectively. These are as per the WHO figures. Despite that, nearly half of the people, or around 51% of the men and 41% of women with hypertension, they were unaware of the condition. Additionally, over 62% of the men and more than 53% of women living with hypertension did not get any treatment also. The medications were used to control BP in fewer than around 1 in 5 men and 1 in 4 men with hypertension worldwide. So this means hypertension is poorly diagnosed and poorly treated. The ISH, the International Society of Hypertension, has released guidelines regarding hypertension, and it has the inclusion of optimal and essential treatment paradigms, attempts to address issues that in resource poor settings. So optimal care refers to evidence-based standard of care, whereas essential standards they refer to the minimum standards of care. Though AHA-ACC, it has released a scientific statement in 2021, and it has a new guidance for the management of stage 1 hypertension among patients with low ASCVD cardiovascular risk. So among the low risk adults, that is, who have a no ASCVD or a 10-year cardiovascular disease risk of less than 10%, with stage 1 hypertension, the management starts with a non-pharmacological therapy. And if the BP remains uncontrolled despite 3 to 6 months of non-pharmacological therapy, you can consider starting treatment, pharmacological measures. And ARDS is a potentially fatal condition involving lung damage, and it is also associated with severe COVID-19. And a recent study which was published in the JACC, it showed that metoprolol can reduce lung inflammation and improve the respiratory function in patients with COVID-induced ARDS. So metoprolol, which is a drug which is used in hypertension, it also has a lot of beneficial effects in for other systems also. One important thing is lowering systolic BP targets down to 110 to less than 130 millimeter range. It has a substantially reduced profile in terms of the cardiovascular adverse events. This was confirmed in the SPRINT trial, that is in an older Chinese population. Among around 8,500 patients aged 60 to 80, the findings from now a major trial, it shows that even among the US professional societies also, the guidelines could be united. That is, the range of the thresholds could be from 130 to 150 millimeters of mercury. And with regard to the prognostic value of ambulatory BP measurement and also the nighttime BP measurement, the European guidelines, they say that the diagnosis of BP should not only be dependent on the office BP measurements, but also ABPM, that is out of office measurements or home BP measurements should be done, 24-hour BP measurements, nighttime BP measurements. They have a greater association with the risk of mortality and the composite of cardiovascular outcome. So they should be considered as the most relevant measurements and not the office BP. So for every 20 bar 10 millimeters increment of BP measured at night, the mortality risk increases by 23%. The risk of cardiovascular events increases by 36%. The most patients with BP require lifetime medical therapy to achieve the optimal BP control. And 5 classes of antihypertensive drugs are recommended by the European guidelines. And so the 2018 European guidelines, they, especially in the context of lower BP targets, they advise to start antihypertensive therapy with an initial dual fixed dose combination of AC inhibitors or ARBs plus CCB or diuretics. And another thing is the HIGIA study. It represents the largest study that tested nighttime antihypertensive therapy. And in this study, chronotherapy was associated with a significant reduction in endpoints. That is, compared whether nighttime BP, that is nighttime therapy of antihypertensive therapy, in comparison to usual the upon awakening hypertension therapy, what is better, and showed that the nighttime therapy exerts a favorable cardiovascular risk reduction. And it was a large study. The largest study included a total of 19,084 hypertensive patients, and during an average follow-up of around 6 years, only 1,752 patients experienced a primary cardiovascular outcome, and an ambulatory BP measurement was performed for 48 hours to collect the data on how BP differed during sleep. And the relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with the awakening treatment. So these are regarding the guidelines about hypertension management. And the most important thing which we should understand is that the antihypertensive therapy has to be initiated when the BP levels cross the targets, and non-pharmacological measures also should be adopted. And the reduction in BP, systolic BP, it offers very beneficial effect in terms of the cardiovascular mortality as well as morbidity. And the lower BP targets, which have been proven by the sprint trial, they have a even better reduction in the mortality and morbidity. So regarding the antihypertensive therapy, it is a very important mainstay of treatment in the cardiovascular diseases. And the recognition of hypertension and the prompt treatment is a very important thing in the treatment of hypertension. Thank you.